further follow-up of the baby. But in our hospital, over the last more than a decade, we just follow a system whereby once the retina matures, we call them back after 3 months. And this is mainly to rule out any media opacities and to confirm, we again confirm the retinal maturity. So next to that, we call 6 months later. This is mainly by that time the child would have grown up a little bit, and now we do the vision check. At least you do a fixing and following of each eye, which itself can be helpful, and see if both eyes is fixing properly, and if possible you can use the vision appropriate charts for vision assessment if possible, which is time consuming but it's good, and also do a routine slit lamp examination. Now you have to reassess the fundus, but you can see that as the child grows, it's not easy to see the periphery of the retina, and many a times the pupil may not dilate also properly. But still try to see whatever much you can do and do a cycloplegic refraction. And after 6 months of maturity of the retina, we do the cycloplegic refraction, which we do with cyclopentolate, or if the child has any CNS issues, we use hometropy. Now I'll talk a bit on our experience with ROP babies follow-up, and what we have seen in the past more than 10 years now. Like, I feel that what we usually see are refractive errors, and these refractive errors, they have an early onset in aggressive ROPs. So nowadays what we do is that we call them back early, and maybe we are doing not much of screening, it's mainly referred patients. So we have seen that most of these patients turn back, and we counsel them so much before leaving them after the injections or laser to come back. And what commonest refractive error, as all of us know, is high myopia with an association of myopic astigmatism. That is what we commonly see. Now coming to strabismus, definitely we do see strabismus, but in my experience what I have seen that strabismus is not that common. Especially you see strabismus like esotropia in cases of high myopias, of high premature babies and those with aggressive ROPs. And also intermittent exotropia is also seen, which is more related to anisometropia. Now when the child comes to you with strabismus, it always warrants a detailed retinal evaluation even under general anesthesia to rule out any macular issues like drag. Because sometimes you may not be able to visualize the macula in all these children. They may not be cooperative. Once they are beyond 6 months of age, it's not easy to see the retina completely and perfectly. So we used to do routine EUAs earlier, and we used to perform EUAs after 1 year of age, and this was mainly to see the periphery of the retina and to assess the intraocular pressures. But now we have restricted this to high-risk group because we were finding it so difficult to give the anesthesia and to get anesthesia fitness. So, and also we have seen that IOP assessment we need not do in all cases, because other signs of increased intraocular pressure itself can help us to get a diagnosis of any secondary glaucomas. And amblyopia, as mentioned, this is the most common, it is very commonly associated with high refractive errors. Especially in cases with aggressive ROPs, we have seen that their vision may not improve to 6/6 or 6/9. Most of them will stop at 6/18 or 6/12, and this is, we don't know what the reason is. Maybe the imaging can help us out, and we are not very good at imaging newborns and small children. It's not easy in our institute. But what I have seen that the vision don't improve beyond a further limit in very high myopes. And as Dr. Lekha has mentioned, like what we have seen that unilateral myopia is very common. In cases of trauma also we see unilateral myopia. So maybe, as Dr. Anand said, it's a mechanism of the eye to grow and protect vision. So that could be the reason for any insult on the eye, they will end up with a myopia. That is quite common. Now, glaucoma, I have rarely seen glaucoma after ROP. Only one case I have seen, and that child is comfortable with topical drops. We didn't have to go for surgery. And lens changes also, cataract also I have rarely seen after ROP, but of late I have seen one case which was laser was done in UAE, came immediately to us with burns on the iris as well as an localized cataract, and we waited, but that cataract progressed and we had to operate the child at 6 months of age. That child is now I think 5 or 6 years of age. Definitely it has developed amblyopia because it is a unilateral one. but we could do a cataract surgery at 6 months and later we put a secondary IOL. And of late, in the last 2 years, I have seen just 2 cataracts. And the thing is, both these children came to us at 3 years of age with the parents giving a history of white reflex. And they came with cataract, and when we examined on slit lamp, we could make out that it was not a congenital cataract, nothing like a lamellar or posterior polar. And on slit lamp examination, we could see the PC dehiscence. So the parents had forgotten about the prematurity and all the treatments that had undergone, because it was like 2 years and 3 years, 2 babies. They had come at an interval of 6 to 7 months, I think, and it was unilateral, and they were given Avastin. So this we have to be careful about. Careful about, like here you can see the PC dehiscence here. So the one surprise is that the patient developed total cataract only after 2 years, and also the child was not amblyopic. We could assess the vision, and one child has a better vision in this eye because the other eye is high myopia. So such trauma to the lens has to be avoided during anti-VEGF. It can happen to anyone because we do it under topical, and the anatomy of the newborn is so delicate that you have to be very careful while introducing the needle, that the child can move the head, and it's really difficult to do it without anesthesia. And also you need a timely referral to other specialities for the global development of the child. That is also important. Then we had done 2 studies, one to assess the ocular sequelae in retinopathy of prematurity following laser photocoagulation. And just like the literature, it was mainly refractive errors. And the second came strabismus, but it was mainly myopia and high myopia in the case of aggressive ROP. And based on this, we did a study to compare these myopes with the full-term myopes. So what we have seen that we had compared children at the age of 7 to 15 years, and we have seen that the preterms with lasered ROP, they had increased lens thickness, shallower AC, and a lesser wide to wide corneal diameter in comparison to the full terms, where we saw more of the axial length was the reason for the high myopia. So literature also mentions, and we feel that it's altered anterior segment development, which is a key factor for the refractive errors, and also the literature also says the lens thickness is a key factor, but the axial length too contributes. So to summarize, I would say stress on the need for long-term follow-up, be more aggressive in the follow-up of AP-ROP, AROP, ideal to keep a ROP directory so that if the parent forget, we insist. We used to do that earlier, but as the number grows, it's not easy for us to. But initial days I used to do that, I used to call back the patients, but now it's not easy, but still if you can keep a directory, it's really good. Thank you.